Today, we're going to talk about a fascinating and sometimes life saving topic. We have here your arrhythmia, whether it's atrial or ventricular, and we're also going to talk about conduction problem of the heart. The heart is more than just a muscle. It's also an electrical system with every beat and tiny electrical impulses which travels through the heart in a very precise pathway, making the chambers contract, okay, and pump blood efficiently. But here's the question. What happens when this electrical system misfires? So, as we go through this topic, I invite you to think of the heart not just as a pump, okay, but as an incredibly coordinated electrical circuit. And we'll explore what happens when the circuit skips, stutters, or speeds up. Okay, let's have your arrhythmia. It states here, referred as an irregular heartbeat. Okay. Electrical impulses in the heart can sometimes become too fast, too slow, or irregular. When the heart doesn't beat properly, it cannot pump blood effectively. And when blood flow is compromised, well, of course, the lungs, even the brain, and other organs may suffer damage or even begin to shut down. So, heart arrhythmias can sometimes feel like flattering or racing heartbeat. Well, many are harmless to consider, but some can be bothersome. And others can even be life threatening, especially if warning signs and symptoms are ignored. Okay? Keep in mind, it is also normal at times for the heart rate to speed up or slow down. That's okay. I'll give you an example. Examination week is coming. So your heartbeat normally or naturally increases during this time. And that's okay. I'll give you another one. When you go to sleep, it is expected that your heart rate or the rhythm of your heart tends to slows down. Okay, and that's perfectly okay. So, how does the heart beat? Okay, to understand what causes bradycardia or tachycardia, it helps to first know how the heart normally works. Okay, let's have a quick recap. Well, of course, your heart has four chambers. Okay, you got four chambers here, two upper, which is your atria, and two lower, which is your ventricles. Okay, the rhythm of the heart is controlled by its natural pacemaker, which we all know, the sinus node, located, of course, at the right atrium. The sinus node sends out electrical signals that trigger each heartbeat, and thanks to sinus node. Okay. These signals first spread across the atria, causing them to contract, okay, and push blood into the ventricles. Then the signals reaches the AV node, a cluster of cells that briefly delays the signal to give the ventricles time to fill with blood. Okay. As you can see, just what I told you a while ago, everything that happens inside the heart is being coordinated properly. There's a proper timing for each action. Okay. The electrical signals travel through the ventricles, making them contract and pump blood to the lungs and to the rest of the body. Okay. In a healthy heart, of course, this electrical signaling happens smoothly, resulting in a resting heart rate of about 60 to 100 beats per minute, which is the normal rate for your HR or your heart rate. Okay, to better understand how the heart pumps, let's briefly revisit its structure and electrical activity. First, take a look at the regular waveform, which is located at the left side of your screen. The PQRST pattern, which I posted here, you'll notice that each wave represents a specific part of the heart's electrical cycle. It's also worth mentioning that the U wave, okay, which sometimes appears after the T wave, okay, the T wave here. Though it's not shown in this image, we'll have it on the next slides. Together, these waves and the segments and intervals between them illustrate the complete depolarization and repolarization cycle of the heart. Okay. Now, let's have a quick recap of the valves that there is. Okay, we have your tricuspid, your pulmonic, your mitral, and your aortic. Okay, four valves in total. Each valve has flaps, okay, also known as leaflets, that open when there's enough pressure, okay, and close to prevent backflow. The heart pumps blood to the lungs and to the rest of our body through a precisely timed sequence of contraction of all the chambers. For this to happen effectively, the chambers must contract in a coordinated way. And that's where the heart's electrical systems comes in. Okay? The heartbeat begins when an electrical impulse is generated by your sinoatrial node or your SA node, located, of course, just like I mentioned before, it's located on your right atrium, which is also known as your natural pacemaker. Okay, we're referring to your SA node here. The impulse travels through the atria, causing them to contract and reaches your AV node, where it briefly pauses. Okay, then it goes down to your His-Purkinje system, which distribute the signal throughout the ventricles, making them contract. Okay. Now, let's try to understand how depolarization and repolarization happens. Okay. When we say depolarization, okay, this is when the heart muscle gets activated and contracts. The heart cell change the electrical charge, allowing sodium and calcium to flow in. Okay. On the ECG, depolarization is seen as the P wave and the QRS complex. So when we are referring to depo, we are also referring to P wave and QRS complex. When we are talking about depot, think of it as the heart firing and pumping blood. Okay? I repeat, when we talk about depolarization, we are referring to P wave and QRS complex. Now let's go to your repolarization. Repolarization is when the heart muscle resets and relaxes. Getting ready for the next beat. Okay? Repolarization happens for heart cells restore their original charge by moving potassium out. Okay? If depolarization allows sodium and calcium to flow in, and repolarization, potassium is going out. Okay, so on the ECG, repolarization is being represented by your T wave. Okay, in repolarization, think of it as is that the heart is recharging so it can beat again. Okay, let's have a quick recap. In depolarization, it is represented by your P wave. Okay, P wave. It's represented by your P wave and your QRS. Okay. And repolarization, of course, it's represented by your T wave. Okay. Now, here's a more detailed view of how a normal ECG looks like. Now, let's start first with your P wave. Okay, let's start first with your P wave. Then again, P wave is under your depolarization, in which your atria contract. Okay, I'll give you a time duration. Usually, when P wave is happening, it's around 0.08 to 0.10 seconds. I repeat, 0.08 to 0.10 seconds. That's around 2 to 2.5 small boxes on the ECG strips. Okay, your P wave starts the cycle as a small upright bump. Okay, as you could see here, there is a small upright bump. Okay, that is for 0.08 to 0.10 seconds. Okay, now let's go to your PR interval. This one, PR interval. What happens to your PR interval is, okay, time from the start of the P wave, okay, to the start of the QRS complex. Okay, I repeat, your PR interval is represented by the start of the P wave up until QRS started. Okay, so the normal duration for that to happen is 0.12 to 0.20 seconds. I repeat, 0.12 to 0.20 seconds. That's around 3 to 5 small boxes on the ECG strips. Okay, so that is your PR interval. Okay, now let's go to your QRS complex. QRS complex. Let's have a recap. Your QRS complex represents a ventricular depolarization. Okay, ventricular depolarization. Okay, in which the ventricles contract. Now, what's our normal time duration for this QRS complex to happen? Okay, take note that in order for a QRS complex to happen, it must be within not more than 0.12 seconds. Okay? Your QRS must happen not more than 0.12 seconds. So that's around 3 small boxes on an ECG strip. Okay? As you could see here on our picture, okay, it looks like sharp, tall, spike with Q dip. R represents the pick, and another S for a dip. Okay, so Q dip, R R pick or R spike, and S dip. Okay, normal duration for our QRS complex to happen is not more than 0.12 seconds. I repeat, not more than 0.12 seconds. That's around 3 small boxes in ECG strips. Okay, now let's go to your ST segment. Okay, your ST segment. ST segment. Okay, from the end of your QRS, so it's around here. From the end of the QRS to the start of the T wave. Okay, as you can see, there's a bump here on your T wave. Okay, from here S to the bump of your T wave, this is when ventricles are depolarized before they repolarize. Okay, I repeat, starting from the end of your QRS complex up to the bump of your T wave, what happens here is your ventricles are depolarized before they repolarize. Okay, so normally it's flat. Okay, and we have a duration period of 0.08 to 0.12 seconds. Okay, your ST segment, which happens from the end of your QRS complex up to the bump of your T wave, that is around 0.08 to 0.12 seconds. Okay, now let's go to your T wave. Let's focus to the bump of your T wave here. T wave. Your T wave represents ventricular repolarization. I repeat, when we say repolarization, your ventricles relax. That's why, as you can see here, it's kind of flat. It's because it's the repolarization period. Okay, it relaxes, so it shows flat line, isoelectric in some terms. Okay, it is normally flat, and sometimes U wave tends to appear after your T wave. Okay, now let's talk about the normal duration of your T wave. Well, there is an exemption to the rule when it comes to your T wave. Okay, when it comes to your T wave, duration is not strictly measured. Okay, when it comes to your T wave, but it is usually wider and longer than your P wave. Okay, your P wave here. So it's around 0.16 seconds, 0.16 seconds. Okay, T wave, this one. Okay, that's around 0.16 seconds before the isoelectric area here, which happens for your repolarization. Okay, so now let's go to your QT interval. Okay, where can we find our Q and T interval? Okay, for your QT interval, okay, time from the start of the QRS, okay, the QRS to the end of the T wave, okay, that represents your ventricular depolarization and repolarization. Okay, the normal duration for this one is 0.36 to 0.44. 0.36 to 0.44 seconds. Well, that's the standard, that's the ideal, but it could varies with heart rate. Okay, so please don't forget your PQRST and U wave. Okay, be mindful of our normal duration period so we could easily figure out if a certain ECG reading is out of normal. Okay, now as you could see on your screen, that's a normal ECG reading. Okay, let's have a quick recap. For your P wave, atria contract, of course, that's around zero point 0.1 second. Okay, for your PR, atria going to your ventricles, that's around less than 0.20 seconds. Okay, and your QRS, okay, in which your ventricles contract, that's around less than, not more than, it's less than 0.12 seconds. And for your T wave, ventricles recover, in which your ventricles recover, that's around 0.16 seconds. Okay? Be mindful that a normal EKG shows steady, as you can see, steady, regular heartbeat, okay, with all the waves, as we mentioned a while back, and intervals appearing in the right order, okay, your P, PR, QR, ST, and sometimes U, intervals appearing in the right order, shape, and timing, okay. Please don't forget our normal duration so we could figure out if an ECG is out of normal, okay. Some arrhythmias are so brief, okay, like a temporary pause or premature beat, for an instance, that they don't significantly affect the overall all heart rate or rhythm, okay. But however, when arrhythmia lasts longer, I repeat, when arrhythmias last longer, they can make the heart beat too slowly, too quickly, or in an irregular pattern. And when this thing happens, this disrupts the heart's ability to pump blood effectively. Anything that goes fast, anything that goes slow is not good for the normal functioning of our heart. Okay? Now, let's have your bradycardia. Okay? We are aware that the normal beats of our heart is around 60 to 100 times per minute. So we could somehow safely say that when we are referring to your bradycardia, it's somewhat slower than your 60 to 100 times per minute. Okay? Bradycardia can be serious if the heart beats so slowly that it can pump enough oxygen, rich blood to the body. Okay? When this happens, a person may feel dizzy, very tired, or even weak, short of breath, or even faint. Okay. However, bradycardia doesn't always cause symptoms or lead to complication. In fact, a slow heart rate isn't always a cause for concern. Okay? For example, a resting heart rate between 40 to 60 beats per minute can be normal during sleep, and that's okay. Or in healthy young adults and trained athletes. Okay? If bradycardia becomes severe, worst case worse happen. An implanted pacemaker may be needed to help maintain an appropriate heart rate. Okay. Now, let's have some of the symptoms to watch out for when we are dealing with bradycardia. Okay. A slow heartbeat may prevent the brain and other organs from getting enough oxygen, which can lead to, of course, chest pain. Okay. Because there is an enough amount of oxygen rich blood supply to the muscle, which causes chest pain. Okay. Not enough oxygen that goes to the brain, which leads to confusion or memory problems. Dizziness or lightheadedness is also included in the list. Fatigue or feeling easily tired during activity, fainting or near fainting, okay, and even shortness of breath. Okay. When we are dealing with your bradycardia on an ECG strip, bradycardia simply means the rate is, of course, slower than the normal, which is your 60 beats per minute. The rhythm is usually irregular. Okay, it's almost the same as the normal one, but the T wave, okay, the T wave, the T wave here also look normal and appear in the right sequence. But where does the problem appears? The key clue in your bradycardia is the distance of your QRS. QRS, okay, are much wider. As you can see here, our QRS here in the normal heartbeat is a bit tighter compared to your bradycardia, are much wider, longer than normal, which shows fewer bits in the same amount of time. Okay, so in short, when we are trying to figure out if a certain ECG strip is bradycardia, the only thing that you have to figure out is the distance of your QRS complex. In bradycardia, it's narrow. Okay, it has regular rhythm but slower rate. Okay, the ECG looks calm and orderly, nothing weird or chaotic to be more specific. But the bits are just too far apart because the heart is taking its time. To be more specific, bradycardia, there's something wrong with the QRS complex. It's a bit different to your normal heart rhythm. Okay, bradycardia, QRS. Okay, next. Okay, your bradycardia can be caused by the following. Okay, we have your heart tissue damage, okay, heart disorder, inflammation of your heart tissue, which is also known as your myocarditis. We also have complication of a heart surgery. Okay, others such as underactive thyroid gland. To be more specific, your hypothyroidism, electrolyte imbalances, your potassium is abnormal, your calcium levels also. Okay, we can also add on the list obstructive sleep apnea. Okay, when we say sleep apnea, there is a repeated pauses in the breathing during sleep. Okay, rheumatic fever or lupus, which is an inflammatory disease. Okay, and even certain medication that could lead to bradycardia, which is a regular QRS complex. To be more specific, we could have sedatives, your opioids, okay, medication that treats arrhythmias, high blood pressure, or even mental health disorder. Okay. Sometimes more than one factor may contribute to a slow heart rate. So it's very important to look at the whole picture when evaluating a patient. So when it comes to bradycardia, don't forget your QRS complex is quite different to a normal heart rate rhythm. Okay, bradycardia, QRS. Now let's go to your um, pathological bradycardia. Okay, in some cases, bradycardia can simply be a normal variation, especially in physically fit or well trained individuals. That's fine, that's totally okay. However, I repeat, however, even a mild degree of bradycardia can sometimes affect a personal quality of life, causing fatigue, dizziness, or reduced ability to carry out daily activities. Okay. Your pathological bradycardia is quite different to a regular bradycardia. Okay. When it comes to pathological bradycardia means the slow heart rate is due to a disease or damage. Okay. Not just fitness or sleep. It often comes with symptoms like dizziness or fainting. On the ECG strip, okay, on the ECG strip, it looks similar to a normal bradycardia, but with some additional or abnormal findings, depending on the cause, of course. Okay, it's just the same with the normal bradycardia, which is less than 60 beats per minute, and the R intervals, sorry, are longer than normal. Okay, showing a slow rhythm. Okay. In some cases, when it comes to your pathological bradycardia, there is a missing beats or pauses or drop in the QRS. Okay. When it comes to rhythm, it's very irregular. P waves, okay. The P waves not always followed by the QRS. Okay. So if the regular bradycardia focuses its problem to the QRS narrowing, pathological bradycardia also includes P waves. Okay. So, pathological bradycardia, P waves, and the QRS. To be more specific, sometimes there is a missing beats or pauses or drop in the QRS segment. Okay, the QRS complex of your pathological bradycardia. Okay. Your pathological bradycardia, the P waves, the QRS complex, and the T waves may look normal if the sinus node is just low. But if it's due to heart block or damage, the pattern may show drop beats where, I repeat, show drop beats where in the QRS. And there is a dissociation between the P and the QRS. Okay. I repeat, when it comes to pathological bradycardia, there is a missing beats, pauses, or drop in the QRS complex. And sometimes P waves not always followed by the QRS. To be more specific, your AB block. Okay. So that's your pathological bradycardia. Now, let's go to your vertical bradycardia. Vertical bradycardia. Now, for everyone's information, your vertical bradycardia isn't a standard medical term. However, What some people mean by this bradycardia or slow heart rate observed in person with a vertical P wave. Okay, a vertical P wave access on the ECG, which is normal variant of an electrical axis, particularly in young, thin, tall individuals or athletes. So, if your patient is young, thin, tall individuals, or even trained athletes, they could somehow suffer from a vertical bradycardia at some times. Okay, so let me explain it in a friendly manner. Okay, when it comes to your vertical bradycardia on an ECG, the heart rate is less than 60 beats per minute, almost the same as your regular bradycardia. So the RR intervals are wider. Okay, I repeat, when the RR intervals are wider, it means slow rhythm. Okay, when it comes to your vertical bradycardia, the rhythm is usually regular with normal PQRST sequence, just slower. Okay, so we could somehow safely say that vertical bradycardia is a slower version of the regular bradycardia, in which the pattern and the sequence are just the same but a bit slower. Okay, that's the key note for your vertical bradycardia. Okay, in simple terms, the ECG shows a slow but regular heart rate. Okay, then again, your vertical bradycardia is the slower version of your regular bradycardia. Okay, with a more vertical P wave direction. And if someone has a vertical bradycardia or someone is positive for a vertical bradycardia, it is usually a normal finding rather than something harmful. Okay. Next, we have your um, medicinal bradycardia. Okay. Medication prescribed for chest pain, such as your metoprolol, propranolol, and atenolol, which is example of your beta blockers, and calcium channel blockers can also cause bradycardia. So I repeat, beta blockers and calcium channel blockers can cause bradycardia. Well, of course, depending on the amount of or severity of overdose. Bradycardia can range from mild to moderate to severe. In in extreme cases, it may even lead to cardiac arrest. Okay? That's why it's crucial to recognize the signs early and start treatment promptly. Okay. Your medicinal bradycardia happens when a certain drugs slow down the heart rate, either by suppressing the sinus node or slowing conduction through the AV or increasing vagal tone. Okay. So what are the medication again? We have your beta blockers, your calcium channel blockers, even your digoxin, sedatives, opioids, and other depressant drugs can be included to the list. Okay. Now, how can we distinguish medicinal bradycardia and an ECG on an ECG? Heart rate, just the same, below 60 beats per minute. With wider RR intervals, then again, if there is an RR intervals, there is a slow rhythm. Usually regular rhythm unless there's a severe toxicity. Okay, so we could somehow say that the rhythm is almost the same with the regular bradycardia. P waves and QRS complex looks normal. It's just sinus bradycardia from medication. Okay. So in simplest term, when it comes to your medicinal bradycardia, the ECG looks slow because the medicine is pressing the brakes on the heart. Okay. The heart is beating slow not because there is a problem when it comes to the rhythm, but because there is a presence of medicine in the system. If mild, it shows a slow but regular pattern. Okay. If severe, let's say it's an overdose kind of situation, it can cause missed beats or irregular rhythms or heart block. To be more specific, it could be within the QRS complex. Okay. Now let's talk about your neurogenic bradycardia. Okay. For those of you who haven't encountered yet neurogenic bradycardia, in fact, bradycardia can also be associated with neurosis, depression, gastrointestinal diseases, or cerebral pathologies. Okay. This type, to be more specific, your neurogenic bradycardia is considered as a symptomatic, I repeat, symptomatic disorder, meaning it occurs as a complication of another underlying condition. Okay. In more severe cases, specific treatment may be necessary. Now, your neurogenic bradycardia occurs when the nervous system, okay, particularly excessive vagal or your parasympathetic activity, which leads to slower heart rate. Okay. So when does your neurogenic bradycardia happens? This can happen with brain injury, or let's say there is increased intracranial pressure, such as your Cushing reflex. We could also add to the list stroke, spinal cord injury, severe pain, emotional stress, or vasovagal syncope. Okay. How can we figure out if the ECG strip is indeed a neurogenic bradycardia? On the ECG, heart rate is below 60 beats per minute, sometimes much lower depending on the vagal tone. Rhythm is usually regular with normal PQRST pattern. Okay. In severe cases, prolonged pauses or even asystole or flat line may occur if vagal tone is very high. Okay. As you could see on our ECG strip here, it kind of looks like a normal ECG strip. Okay. On the topmost is the normal one, but on the bottom one is a representation of your neurogenic bradycardia. It's almost the same, but with much lower. Okay, so there is a bit of gap here. So your neurogenic bradycardia, okay, the ECG shows a slow but regular rhythm, caused not by the heart itself, but by the brain or nervous system sending too many slow down signals to the heart. If severe, it may also show very long pauses or missed beats. Okay, as you could see here, there is a quite distance which show a very long pauses. Or, worst case scenario, miss bits. Okay. Now let's go to your vagus bradycardia. Now let's go to your vagus bradycardia. This particular type of bradycardia is often called functional. Okay. Because there is usually no structural or organic damage to the heart muscle. So, what's wrong with your vagus bradycardia? Despite its relatively favorable prognosis, it still requires appropriate treatment to prevent complication. Okay. Your vagus bradycardia happens when the vagus nerve, okay, to be more specific, your parasympathetic nervous system overactivates. We all know that your parasympathetic nervous system, if it's overly activated, it releases acetylcholine, which of course responsible for slowing down the sinus node and AV conduction. Okay. When does your vagus bradycardia happens? Okay. If there is a vasovagal syncope, such as fainting due to stress, pain, or fear, carotid sinus massage, okay, sleep, vomiting, or straining. What I mean is Valsalva maneuver. Okay. Now, what is the distinctive characteristic of our vagus bradycardia when it comes to the ECG? Okay. Well, let's start with the heart rate. Well, it's the same, 60 beats per minute, slower than that. Regular rhythm if mild, normal PQRST sequence but slow. In more profound cases, there are sinus pauses, long flat line between the beats. Okay, long flat line between the beats. Okay, as you can see here, low flat line between the beats, or even drop beats, or even brief asystole if very strong vagal response is presence. In simple terms, for your vagus bradycardia, the ECG shows slow heart rate rhythm, sometimes with pauses, because the vagus nerve is hitting the brakes on the heart too hard. Usually, it resolves once the vagal stimulation stops. So, in short, there is an irregularity if the vagus the vagus nerve are being stimulated. Okay, so that's your vagus bradycardia. Now let's jump to your or your tachycardia. What happens when a certain someone or a patient per se is having a tachycardia? Okay, your tachycardia occurs when an irregular electrical signal, starting either the upper or lower chamber of the heart, of course, causes the heart to beat faster than normal. If your bradycardia is slower than 60 to 100, it's the opposite when it comes to your tachycardia. The heart rate is over 100 beats per minute. Several types of arrhythmias can lead to tachycardia. A fast heart rate isn't always dangerous. For example, it's normal for the heart rate to increase during exercise or in response to stress. That's perfectly okay. Tachycardia may not cause any noticeable symptoms or complication. However, if left untreated, Some forms can lead to serious problems, including heart failure, stroke, or even sudden cardiac death, which we hope it doesn't happen. Okay? So, what are the possible treatment that we could do for your tachycardia? Okay? There are specific physical maneuvers that we can do. We can give medication. Okay, we could also do cardioversion, which is an electrical shock to reset the rhythm. Okay, we could do that. Or undergo a surgery or other procedure to control the rapid heartbeat. Okay. What are the common signs and symptoms when it comes to your tachycardia? Of course, there is a sensation of racing, pounding, or flattering heartbeat, or much known as your palpitation. There is chest pain, of course, fainting or syncope, near fainting, lightheadedness, rapid pulse, and SOB or shortness of breath. Okay? You know what? Some people with tachycardia have no symptoms at all. Nothing. Okay? It may only be discovered during a physical exam or test and for another reason. Okay? So, how can we define your tachycardia? Tachycardia under an ECG. Okay? If in bradycardia there is a longer RR intervals, when it comes to tachy, it's short. Okay? There is a short RR intervals because the beats comes closer together. Heart rate is more than 100 beats per minute, that's given. Okay? The rhythm can be regular or irregular. Okay? Your P waves may still be visible and normal in such tachycardia, sinus tachycardia. It may be hidden, inverted, or absent in other tachyarrhythmias. Okay, let's talk about the QRS under your tachycardia. The QRS, the QRS under your tachycardia is usually narrow if the impulse starts above the ventricles or your supraventricular. Okay, but may be wide if it starts in the ventricle. Okay, I repeat, your QRS is usually narrow if the impulse starts above the ventricle. Narrow above the ventricle. Wide if it starts in the ventricle. Okay, I repeat, QRS is usually narrow if the impulse starts above the ventricles, or also known as your supraventricular, and it could be marked as wide if it starts at the ventricle itself. Okay. In simple term, the ECG looks busy. The heartbeat becomes too fast, and the spaces between the QRS complex or your RR intervals are much shorter than usual. Okay. In short, when it comes to tachycardia ECG result, everything seems squeezed together because of the rapid rate. Okay, I repeat, if the heartbeat is faster, the ECG strip is a bit squeezed together. But if it's slower, everything is expanded. Okay? Now, what are the possible causes of our tachycardia? Okay, given at your screen, we have fever, alcohol use, high levels of caffeine, high or low blood pressure, imbalances of substance, okay, your electrolytes. It could be a result of medication side effects, overactive thyroid, your hyperthyroidism. We could also add on the list your anemia, okay, or often due to blood loss. Smoking is also possible. Use of illegal drugs such as stimulants, for example, your cocaine and methamphetamine. Okay, identifying and addressing the underlying cause is the key management in dealing your tachycardia. Okay. so we could be effective in addressing the problem. Okay? Now, let's go to your atrial fibrillation, or also known as your AFib. Okay? Now, the most common type of your tachycardia is your AFib. Okay? It happens when a chaotic, or let's say irregular electrical signals in the upper chamber of the heart, which is the atria, okay, cause the heart to beat rapidly and irregularly. Okay, your AFib can sometimes be temporary, but in some cases the episode won't stop on their own and require medical treatment. Okay, so how can we figure out if the ECG strip is now an AFib? Okay, on the ECG, the rhythm is irregularly irregular. Okay, no predictable pattern between the RR intervals or your QRS. There's no distinct normal P waves. Okay, the P waves are so erratic, so chaotic. Okay, instead you see wavy, okay, erratic baseline. These are your P waves. It seems like they are panicking. Okay, QRS complex are usually narrow, as you can see. QRS narrow, and appear at irregular intervals. As you can see, the QRS here is much different from the QRS here and here. Okay, in short, when it comes to your AFib, the ECG looks messy. Okay, the ECG looks messy. The baseline, which is your P wave, which is also known as F wave sometimes. Okay, no clear P waves because the atria are just quivering instead of making one strong contraction. Okay. Now, in AFib, okay, students often remember it as irregular rhythm with no P waves and a wavy baseline. No P waves and wavy baseline. Okay, that's your A fifth. Now let's go to your A flatter. Now, let's talk about your A flatter. Okay. Your A flatter is somewhat similar to your AFib or your atrial fibrillation. But the heartbeats are more organized and regular, though still faster than normal. Okay, if we're going to compare the ECG strip of an atrial flutter to an AFib, atrial flutter ECG is much better looking. Okay, but still faster. Okay, episodes of atrial flutter may resolve on their own, but sometimes medical treatment also is wanted. It's also common for people with atrial flutter to experience atrial fibrillation at other times. So, we could somehow safely say that if someone is suffering from A flatter, there is a chance that their rhythm could end up to a AFib. Okay? Now, how does an A flatter looks on an ECG? Well, as I mentioned before, a while ago, the rhythm may be regular or slightly irregular. Okay. The key note for your A flatter is the saw tooth. Okay. Saw tooth. Okay. It's like a chainsaw. Okay. That's why they call it saw tooth. Flatter waves, F waves. Okay. There is no clear baseline, but much better compared to your AFib. Okay. The QRS complex usually appear at a slower or regular rate, depending of course on how many atrial signals make it through the AV node. Okay. Usually it's 2 is to 1, 3 is to 1, 4 is to 1 conduction. Okay. But compare to your AFib, your atrial flutter is much nicer to look at. But both ways, they are both faster compare to your bradycardia, of course. Okay. Now let's go to your ventricular or your VTAC. Okay. One of the most chaotic ECG there is. Okay. Your VTAC has a problem that originates in the lower chambers of the heart. Okay, that's why it's called ventricular tachycardia. The problem is from the ventricles. Okay. The rapid heart rate prevents the ventricles from filling properly and contracting effectively. Okay. Which means the heart can pump enough blood to the body. Okay. Episodes of VTAC or your ventricular tachycardia may be brief, lasting just a few seconds or causing little or no harm. However, I repeat, however, if they last longer, they can be life threatening and require immediate medical attention. Now, let's look at the ECG that we have here. Okay. Heart rate is very fast, usually around 100 to 250. I repeat, 100 to 250 beats per minute. Now, the rhythm is usually regular with evenly spaced QRS complex evenly. As you can see, they are almost identical. QRS. Okay. QRS are wide and bizarre looking. It's skyrocketing compared to the normal one. Okay. Because the impulses do not follow the normal conduction pathways. As you can see here with the normal heartbeat, the P waves are still present. But due to the fact that when it comes to the VTAC, the heart rate does not follow the normal conduction pathways, making the P waves absent. Okay, there is no P waves during your VTAC. P waves are usually not visible or had no clear relationship to the bizarrely looking QRS complex. Okay, I repeat, when it comes to beta, there is no P wave. But bizarrely looking QRS is very much present. Okay. In short, when it comes to your VTAP, the ECG looks fast, wide, and regular. The ventricles are beating on their own. And the usual PQRST pattern is loss. Only QRS is present. Okay, it can look a row of big uniform waves matching across the strip, which is the QRS only. Okay, so that's your VTAC. Now, let's go to your supraventricular tachycardia, or also known as your SVT. Now, your SVT is a broad term that refers to arrhythmias that start above the ventricles. Okay, if your VTAC starts at ventricles, your SVT start above the ventricles, usually the atria or the AV node. Okay, the key feature of your SVT is that it causes episode of a sudden pounding heartbeat, or much known as your palpitations, that begin and end abruptly. Okay. So how does your SVT looks like in the ECG? Heart rate is usually around 150 to 250 beats per minute, much faster than normal. Okay. The rhythm is irregular The QRS occur evenly. Okay. The QRS is narrow. The QRS are narrow because the ventricles are still activated through the normal pathway. But the P wave is kinda or often hidden inverted or appear right after the QRS. Okay. Because atrial depolarization is happening at almost the same time as ventricular depolarization. Now, for your SVT, the ECG shows a very fast, regular rhythm with narrow QRS, 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 QRS. Okay? And there is no clear P waves. It looks like a rapid, clean row of QRS complex marching quickly across the strips. Okay, almost the same description with your VTAC. But the distinctive characteristic of your SVT is there is an inverted. Okay? Inverted. Next, we have your ventricular fibrillation. Ventricular fibrillation. The upper part is a normal ECG reading, and of course, the ventricular tachycardia is at the bottom. Now, let's talk about your BFib. Now, your BFib is considered dangerously rapid rhythm caused by a chaotic electrical signals that makes the ventricles quiver, okay, instead of contracting in a coordinated way. Kinda sounds like your VTAC again, okay. This is a life-threatening emergency. If heart rhythm is restored within minutes, it can lead to death. Okay, if someone is suffering from ventricular fibrillation and within minutes responder doesn't make it, it can lead to possible death. Okay, but what is so distinctive when it comes to your BFib? Okay, most people who develop BFib have an underlying heart disease, okay, or suffered serious trauma such as being struck by lightning. Okay, now on the ECG, okay, there is no identifiable P wave. P wave is nowhere to be found. QRS, complexes, or T waves. We can hardly say where is QRS, where are the T waves, where are the P waves. Instead, you see wavy erratic baseline, like scribble bag of worms, okay, with no organized pattern. The rhythm is irregular and disorganized, and the rate is unmeasurable. I repeat, when it comes to your BFib, the rhythm is irregular, disorganized, and the rate is unmeasurable. Okay? So when it comes to BFib, based on this ECG, this reflects that the heart is not pumping at all. It's a medical emergency. Okay? So, how can we prevent? Of course, choose food rich in whole grains, lean meats, low fat dairy, plenty of fruits and vegetables. Okay. Limit your intake of salt, sugar, alcohol, saturated fat, trans fat. Aim for at least 30 minutes of physical activity most of the days of the week. Healthy weight. Being overweight increases your risk of the heart disease. Okay. Control your blood pressure and cholesterol. Follow lifestyle changes and take prescribed medication if there is. Quit smoking. If you smoke and struggle to quit, talk to your healthcare provider about programs and strategies to help you stop. and use medication wisely. And of course, to those who are coffee lovers, sad to say, you have to limit your caffeine intake. If you drink caffeinated beverages, do so in moderation. No more than 1 to 2 beverage daily. That's it. That's the maximum. Okay? Manage stress and of course, attend your checkups religiously. Have regular physical exams and report any changes in your heartbeat to your healthcare provider, of course. If your symptoms change or get worse or you develop new ones, please tell your healthcare provider immediately.